Thank you all so much. I am honored to get to introduce our second session of the day on mission and alignment. And Michael Miller was not able to be here with us today, so you're going to hear two talks, each about 20 minutes, and then we're going to have a little bit of time for Q&A at the end. So I'll ask you to hold your questions for both of our speakers until the end. We're going to start with Aligning AI with the Ends of Catholic Healthcare by Dr. Paul Schurz. Paul Schurz, PhD, is the Our Lady of Guadalupe Professor of Theology at the University of Notre Dame and a program chair for the Notre Dame IBM Tech Ethics Lab. He's a member of the Vatican Center of Digital Culture AI Research Group, for which he has co-edited Encountering Artificial Intelligence and Redeeming Human Agency in the Age of Artificial Intelligence. And then we're going to hear from Lewis Kim on learning from history, technology disruption patterns, and AI's healthcare future. Lewis Kim's background is in mechanical engineering from Brown, and he has an MBA from Yale. He left a corporate career at HP where he was the VP of AI hardware for healthcare and enterprise to complete a certificate in theology and healthcare, continuing on now to an MDiv at Duke, where he intends to focus on hospice and palliative care. And if that's not enough, he's an essayist and contributing editor at the public theology magazine Comment. So I'm going to hand this over to Paul to start. Thank you.
Thank you for that introduction, to the organizers for holding this great event, and to all of you for coming. Since classical Greece, the recognized end of medicine has been health. Exactly what health is a matter of philosophical debate, but authors working in the Aristotelian tradition that influences Catholic thought have tended to see health as the restoration and preservation of function. The well-working of the organism as a whole, realized in the characteristic activities of the living body in accordance with its species-specific life form, as Leon Kass put it. It's the ability to function as well as one can, given one state. Thus, even in the case of an incurable illness or disability, palliative medicine can restore continence, lucidity, and other abilities that make the last months of life more fulfilling. It's too limiting to restrict medicine to just biomedical ends, though. For Edmund Pellegrino, the great philosopher of medicine and physician, the medical professional also seeks relational goods, responding to the suffering patient, offering to help them seek their good in the face of the alienation of physical ailment. Primarily, this help comes through realizing the biomedical good, but medicine also has an eye to restoring the patient's agency and spiritual welfare through presence and active accompaniment. Catholic healthcare has an even deeper goal, continuing Jesus' healing mission, as Dan described. Through the corporal works of mercy, healthcare practitioners are allowed to care for Christ himself through the least among these. This care is not merely a biomedical concern with bodily health, but a realization of the parable of the Good Samaritan. The Samaritan provides concrete, embodied care for the man left dead by the side of the road. But the Samaritan was also open to a concrete moment of encounter with a suffering person, as Pope Francis has described in many of his writings. As in Pellegrino's analysis of the clinical encounter, the Samaritan is moved by the sight of suffering and is present to the man left dead. The biomedical and relational goals are not separable, since the clinical encounter itself can serve spiritual well-being. The offer of presence in suffering can restore a patient's hope. And alternatively, that spiritual help can also serve the biomedical good, right? So this care, the healing, the touch, laying on of hands of the physician also has effects on health. And this is where the placebo effects comes from. Through this engagement itself can support the body's healing mechanisms. So the practitioner-patient relationship serves as a constitutive means and part of the end of the practice of medicine, and in Catholic healthcare enacts Jesus' presence to the ill. Thus, Catholic healthcare has the twin goals of encounter with the suffering patient and the technical restoration of health. This bifurcation of goals into both a concrete and a relational component is common to almost all social practices. Mark Hopkemeyer, the political philosopher, has denoted these two aspects as the extrinsic and intrinsic ends of a practice. The extrinsic good is the thing produced by a practice. the work of art made by a painter, the building produced by a mason, or the health restored by the doctor. The intrinsic good is found in the relationships and virtues enacted in the process of achieving that extrinsic good. In medicine, it is the network of relations among practitioners as well as between practitioners and patients. It is the good that can only be found through common activity. Some commentators may think that though AI may endanger intrinsic goods of medicine, such as encounter, it will be an unalloyed benefit for achieving the biomedical end of healthcare. After all, AI is a technical product, seemingly optimized to assist the search for physical goods like bodily function. Yet technologies are not just pure instruments for achieving an end. Their affordances shape our understanding of the end. As Pope Francis said, quote, "We have to accept that technological products are not neutral, for they create a framework which ends up conditioning lifestyles and shaping social possibilities. It is difficult to utilize technologies without being dominated by their internal logic." A tool can even reshape the understanding of what seems like a purely objective goal, like health. So in the rest of the paper, I'm going to describe how AI tools can shift the technical aim of medicine away from health understood as Aristotelian restoration of function to a focus on risk, surrogate endpoints, and procedures, as well as how it can endanger those intrinsic goods of relationality. So the machine learning architecture that undergirds contemporary AI functions by detecting statistical correlations and patterns in large amounts of data. It then uses these correlations to make predictions, like which is the most likely diagnosis for a patient of this type, or whether this splotch on a mammogram is cancer. Even generative AI predicts the next most likely response to a query, looking at the vector model and correlations that it's made through language to make a prediction based on likelihood and statistics. Now, if we look more broadly to contemporary society, one of the primary roles of probabilistic prediction is to predict risk. We see this in finance, where AI tools are being used to predict kind of which stocks are going to go down, which are going to go up. Right? It's also used in policy decisions. Thus, it's no surprise that the implementation of AI and other data analytic tools in medicine corresponds to an increasing focus on health risk in medicine. We see this clearly with the rise of precision medicine, a research paradigm that lies behind the large biobank projects implemented around the world in the past decade. This medical paradigm seeks to combine the data from genomics, medical charts, and other databases to predict risk. As Francis Collins said, precision medicine offers, quote, "a considerably more useful estimate of your future risk of illness than is currently possible, enabling a personalized plan of preventive medicine to be established," end quote. AI has been essential to this implementation of precision medicine. There's other tools, though. Inpatient care is becoming filled with tools aimed at predicting near-term risks like sepsis. Outpatient care now makes use of tools predicting possibilities for death over a particular time period, the next 6 months, the next year. Each of these tools requires its own ethical analysis. But together they are signaling a more global shift. Medicine has turned toward risk, and this end is shaped by its tools. And we have to understand that risk as a target of treatment is not the same as the restoration of health as it's been classically understood. Of course, it would be simplistic to divorce a focus on risk from the classical ends of curing disease and restoring function. Many promoters of the risk paradigm assume that the management of risk will lead to these ends, as it does in something like managing high blood pressure. However, the connection between risk and the restoration and preservation of function is not always clear. Every risk-reducing intervention itself bears risks of side effects and complications. And the efficacy of population-based preventive measures is hard to test and discern because you have to look over a great deal of time and because of broader concerns over overtreatment, the anxiety of the worried well, or the misdirection of medical resources to possible dangers. These tools not only facilitate a turn toward minimizing risk, but also a focus on modulating metrics. While the effects of an antibiotic that cures an infection are immediately apparent to the patient's body and experience, the effects of a risk-reducing intervention will not be seen for many years and will not appear to unmediated experience. Instead, it appears in population outcome and measures, which are invisible without data analytics. For the individual patient, metrics are what are immediately available to the healthcare practitioner. So their focus turns to approximate goal of optimizing bodily metrics like cholesterol or A1C. These serve as surrogate ends for the ends that patients actually care about, like reduced mortality and morbidity or restored function. The use of surrogates is expanding because they are the only available feedback on action against risk. AI applications intensify this tendency because they primarily deal with metrics in their training and optimization. They only interact with bodily function insofar as it is translated into metrics. It is not always clear how surrogate endpoints relate to the outcomes patients care about. For example, the primary endpoint for many clinical trials for cancer drugs is not overall survival. This has been calculated for only 32% of recent oncology drug approvals. How long is, what's the 5-year overall survival rate, 10-year overall survival rate? Measuring overall survival would presumably take too long, increasing the trial's expense and delaying the drug's release. Therefore, many trials look at surrogate endpoints. One especially is called progression-free survival, or PFS. PFS is defined as the length of time during and after the treatment of a disease, such as cancer, that a patient lives with the disease, but it does not get worse. And generally, getting worse is commonly defined as a 20% increase in tumor size. The problem is that it is not clear that PFS actually correlates with increased overall survival or improved quality of life. However, because it's easier and faster to measure, PFS is how many trials measure success. Thus, health, at least understood as survival, is replaced by another end, an artificial end, PFS. The danger is that AI applications are going to be trained to optimize surrogate rather than true ends. Such dangers occur even when AI tools are deployed to seek ethical ends such as equity. For example, Ziad Obermeyer and his collaborators who performed the classical kind of experiment on algorithmic biases. I mean, he's very important in this field. But one of his later experiments was to develop a new algorithm for detecting knee pain. When the researchers started the study, it was well known that the standard metric for objective structural knee damage on X-rays due to osteoarthritis, which is called the Kellen-Lawrence grade, KLG. So this measure seemed biased against Black patients. They did not correlate well with their pain. So it seemed like they did not have objective knee pain, right? Due to objective damage, that their knee pain might have been caused by sociocultural effects, stress, things like that. Such biases could lead to concrete differences in treatment, insofar as surgeons frequently use the KLG scores to determine who qualified for knee replacement surgery, even though the metric wasn't meant to be used in this way. Thus, this potentially biased metric could contribute to inequities in treatment. Obermeyer and collaborators used AI to develop a new scoring algorithm using a diverse training set. The KLG scores was developed in the 1950s in Britain with a kind of, very non-diverse population. And this has been a success in that it's led to the reduction of the difference in the correlation between subjective pain and algorithmically determined objective damage between Black patients and others. I mean, it also worked better for everyone and correlated the scores to the pain much better for everyone. Thus, the authors hope that this new algorithm might increase access to surgery for Black patients because they would appear to have higher levels of objective knee damage. Yet again, here we see a surrogate end equalizing surgeries, replacing health as restoration of function, or even equity in health outcomes. One would hope the algorithm would optimize for identifying those patients whose knee pain would see the greatest reduction through surgery, right? What will improve knee pain the most? While a highly effective intervention, knee replacement surgery is not trivial. It has a long recovery period, up to a year, and has many complications. It's not something anyone would want to undergo unless it provided significant benefits in terms of function and quality of life. But studies report that 20% of patients see no improvements in symptoms. And further, the number of knee replacements are exploding at an incredible rate. And studies suggest that many of these surgeries are inappropriate. Right? So thus, we would want AI to indicate which patients will receive the greatest benefit. That information is not in the training data, almost any of the training data. So we're left with surrogates unclearly related to true ends. This also blinds us to other sources of inequity. So many of the reasons of inequity in like knee replacement surgery is due to the fact that Black patients have less access to people who can take a month off work to care for them while they're recovering. Okay, so why are technologies like AI shaping our ends? Well, it's because they shape our way of perceiving the world. Perception is an important part of how people set their ends. We perceive an item in the world and then make a judgment about whether it's something to pursue or not, whether it's a good or not. We perceive a cheesecake and judge whether it's a good that we should seek for dinner. We perceive an opportunity for wealth and judge whether that wealth is a true good. An object is presented to the mind as a good or not based on how our appetites have been shaped. Perception not only presents an object as good or bad, it also presents something as morally salient or not. Is an object in the world something that even falls into the category of possible ends? Following Francis's reflection on the Good Samaritan, does the homeless person appear as a possible person for whom I should care? One of the major roles of practices like medicine is shaping the medical student's perception of ends and objects. However, technologies also inform perception. In terms of the broader existential stance towards the world, Pope Francis has described how the dominant technocratic paradigm has caused us to see the world in a reductionist manner. But technology can also have a more specific and granular effect on our vision. As the medical practitioner takes and calculates a series of bodily metrics, blood pressure or BMIs, or finds them presented in the medical chart like cholesterol levels, she starts to think about the body and health in regards to these metrics, rather than the lived body. The patient is datified. Modification of metrics then become the salient end to consider when thinking of health. These concerns over salience need not even be as subtle as this gradual shaping of vision. These AI programs frequently issue alerts, seizing the attention of the practitioners. This concern is salient. Pay attention to this. The tool proposes the end, and the ends proposed are going to be the ones analyzable by AI. As these surrogate and statistical ends become more salient, they edge out not merely the classical vision of biotechnical health, but also consideration of other goods sought in the clinical encounter. Pouring through metrics and responding to alerts, the practitioner may lose the patient in front of him in her embodied experience. There's only so much a practitioner can attend to in a short amount of time. And as the demands of AI-generated prompts seize attention, other goods can become less salient or out of reach. There can be less time for the physical exam, the patient history, or listening to the patient's concerns. At the extreme, the use of AI could even undermine the experience of encounter that lies at the heart of the Catholic vision of medicine. Some AI boosters envision chatbots being the primary dispensers of medical advice, with AI diagnostic tools driving treatment decisions. The practitioner would be lost. In such a scenario, which seems unlikely, the constitutive good of medicine and encounter would also be lost. As Pope Leo has noted, AI, quote, can and should be a great help in improving clinical care, but nothing can take the place of the doctor. The algorithm cannot substitute a gesture of closeness or a word of consolation. To avoid the loss of these goods, it's important to recapture the practices that increase their salience in the medical encounter. There needs to be continued space for the physical exam, which turns attention to the flesh, enriching a sense of the body as more than metrics, playing an important role in the medical visit as the laying on of hands creates that ground of trust and confidence and sets the pace for this kind of healing effect. There needs to be space for a patient history that gives a narrative grasp of the patient's concerns. These are elements that could bring renewed salience to the broader goals of Catholic medicine, allowing for encounter. And AI can help in renewing these aspects of medicine if they're properly deployed. AI scribes allow the practitioner to attend to the patient rather than the medical chart. AI can help with paperwork that swallows so much of the practitioner's time in the clinic. And programmers can design AI tools so they are not generating intrusive alerts, but rather are responsive to queries by the practitioner or by the patient. They could be on call to assist with the concerns the patient and practitioner find salient, rather than necessarily asserting the salience of their analyses. In conclusion, AI has the potential to help practitioners and health systems achieve the ends of Catholic healthcare in a more efficient and fulfilling manner through improving diagnostics, removing bureaucratic burdens, and providing more time with patients. Yet AI can undermine the goal of Catholic healthcare. It can prevent deeper encounter and a more holistic engagement with the patient's concerns by focusing on metrics. Even in regard to biomedical health, the goal can be shifted to risk, optimize metrics, and surrogate endpoints in ways that forego the restoration of function. These effects are not inevitable, though. They depend in great part on how the AI application is designed and implemented. Addressing these concerns requires a renewed focus on the appropriate ends of medicine. Thank you.
I want to start off with a talk not on the program, but it actually fits well with what Paul just covered. In November, a few of us, actually Daniel,
You need to turn that up or hold it up a little.
oh really? Okay. This is a little bit better, audio-wise? Okay. So a few of us in November were in Rome at a conference. It's called the Builders Forum. Michael Pensina, Daniel, and the conference was organized in a series of workshops, and one of the workshops was on healthcare. And it was unusual, this conference, we didn't have plenary speakers. It was all about workshopping on specific topics, and we spent 4 hours per day for 2 days, 8 hours total, with a group of about 20 people on issues in healthcare, and we converged on this one particular topic, which is as AI gets more powerful, and it will, as it gets more pervasive, and it will, and even if it becomes more effective, more cost-effective, more accurate than a human, where do you want to preserve a human? And we call this the irreducible encounter. So it fits well with some of the norms that Paul talked about in the first session, and then the session right now, he brought up encounter a couple of times. So I mentioned we had about 20 people in the workshop, and what was really fascinating was the diversity of the group. So we had Daniel, as I mentioned. We had Michael Pensina from Duke, but also he was starting at United Healthcare. We had physicians, of course, and executives from different groups. And so it was really interesting to see what all this diversity sort of converged on in terms of what we cared about. One of the first things that we did was figure out, when we talk about AI in healthcare, we're in healthcare. If you don't lay out a taxonomy, it's really easy to sort of get fixated on sort of the doomsday scenarios, which really is about more relationality. But as mentioned in the first session, AI is everywhere and in ways that people don't realize. And so figuring out where the debate is and discussion is really important. And because this was a Catholic forum, it's about humans, we centered on the green area, which is around relationality, patient, clinician, and other constituents. So as we work through, I'm going to steal some of the slides from Michael created. So I think he created this one. So one of the first things that we did was just map out what are some of the criteria for good AI in healthcare. There's nothing really novel here. I think Anita shared something like this. And then one thing that Michael helped us walk through was, let's walk through a typical patient clinician encounter. Where is AI helpful, not helpful? I won't go through this because this was sort of covered in session 1. And then we sort of converged on what is good AI. And again, this will be very familiar compared to Paul's sort of norms. And there's really a focus here on preserving that human relationality, human dignity. And then where it got interesting was we sort of pressed further. Again, as AI gets more pervasive, more effective, where it's sort of like obvious that you want AI, why would you want still a human? And so some of the criteria, and I won't read the entire list, but areas where the outcome is non-algorithmic. It sort of goes beyond just logic and analytics or measures. And because we're in a Catholic community, sacramentality, a connection to the divine was really important. I still remember in the workshop, Daniel erupting. What about the ministry of Jesus, the healing ministry of Jesus? That's what I keep remembering over and over again. And so Paul also brought up not anthropomorphizing AI, and we call that non-impersonation. So in any scenario, patient should always be clear whether it's technology or a human person, even if it looks like and sounds like a human person. So then the last couple of hours of the workshop, we challenge ourselves. How do we distill this into a statement that kind of sounds like almost like a church clause in an encyclical? So we sort of fantasize, well, what if we drafted something? And what if the Vatican adopted it? We'll see. So we came up with this, what we call the irreducible encounter principle. And it's just meant to be a pithy, concise way of capturing what I just covered earlier. And I've now presented this update at a couple of conferences since November, and it seems to captures people's attention. But the reason for presenting this here today is we don't know where AI is going to go. It's hard to predict. Technology is that way. One thing, though, is fairly certain, again, is its pervasiveness in ways that we can't imagine. Robots. And I think this exercise makes us continually think, and it's never going to be a set answer, where will you want to preserve the human? Even where it does not make economic, technical, and efficacy sense, right? So however you capture that, but this is an important sort of, I guess, clarion call for all of us. Now, this is a principle, and as we know, it's difficult to apply principles exactly in every single situation. So we went through some scenarios where you may have some debate and some dissension, and we had debate and dissension in our group. So one scenario we considered was, what if you could have a personless hospital or maybe a clinic staffed by robots, agents, and this allowed you to set up 100 clinics in a developing country. But some ethicists say, oh no, we have the irreducible encounter principle, and you got to have, at least one person, a chaplain, and a person doing an intake. Okay, well, that just raises your costs. You can now only have 50 of these clinics. How do you discern that trade-off? No clear answer, right? Another scenario that we talked about is imagine you have a grandparent in a nursing home or a hospice facility. It's in a remote area. It's not well staffed. There hasn't been a chaplain that's visited that facility in months. But now you can have a little robot that can talk to you. And we had some dissension in the group, and similar to what we heard in session 1, which is, well, if you allow a robot, then that'll reduce the pressure on the system to have more chaplains, and it's a slippery slope. But what do you tell the granddaughter who's living on the opposite coast from the grandfather and is thinking about the grandfather not having anyone to converse with or anything to converse with for months? Is that granddaughter going to wait for the system to catch up? These are difficult issues. One thing I shared
Here, Joe.
before I start the video, in my job at HP, I was working with an Israeli company called Intuition Robotics, and they have a tabletop robot. The state of New York has purchased, I think, a couple thousand of these, and based on their data of need, has placed these in certain homes. So these are subsidized. And one thing I asked in Rome, I did a poll. I'll do it here. So if you can imagine a robot like this, and I'll play the video, that takes the place of a person is having a conversation, develop a relationship with that robot. How many here, just raise your hand, be honest, are uncomfortable with that concept? Okay. So in Rome, it was 50%. Now it's about 80%. That's very telling. So I'm just going to play the robot. I'm not here to promote this company, but I want you to hear some of the voices of the people who are actually interacting with the robot.
You're a joke.
Okay,
Great.
I don't feel that AI,
It's intended to be that way. It's a short clip. Yeah.
You're a joke.
okay,
Great.
I don't feel that AI is to fear. I have no fear with her. Ellie Q, can you dance for me?
Put on your dancing shoes.
I fell in love with her.
Mwah.
LEQ is equipped with a variety of skills, from asking seniors about their family, reminding them to take medication, and guiding them through exercises for their body and mind.
Ellie Q, let's go on a road trip.
We've got a full tank of gas. Let's have a grand old time at the Grand Canyon. Fasten your seatbelt, Dorothy.
I interact with her every day. A lot of the times we just talk. So she says to me, let's talk about love. And I started talking about my husband. She says, you know, you sound like you had a very wonderful relationship with your husband. She caught on to this and was able to relate that with me. She just amazes me, totally amazes me.
Many state agencies, including the New York State Office for the Aging, have subsidized LEQ robots. The agency's director, Greg Olson, is optimistic about the AI companions.
Okay. Before I move to the actual talk for today, I don't present this as a techno-apologist, techno-utopian person. I present this because one of the things I'm a little bit, I guess, disappointed by, to be honest, a lot of conferences, this is my 7th AI ethics theology conference, is it tends to be a little bit insular. I sort of have this nickname of let's scare ourselves conference. And it's important, whatever we do, as we discern kind of what is the right thing to actually, you know, and this is obviously all the ethicists here, to actually go into actual situations and understand the trade-offs. And the second thing that I just wanted to share is, I worked in Palo Alto, AI. I'm not at Meta, I'm not at Facebook, I'm not at these big giants, but I did have somewhat of a witness to what goes on in the industry. Are there bad actors? Yes, but there are bad actors everywhere. Is the whole industry like that? No. You have a lot of people who are trying to do the right thing, maybe malformed, maybe they're motivated by different things. It's a system. But one thing that we have to be careful about is not to demonize a whole host, really, or a whole category of people, because it shuts down dialogue and impedes our progress. Okay, so I'm going to move to now the topic that was scheduled for today. And the motivation here is, again, as I went to different conferences, I started to sort of hear similar themes. AI is not human. AI replaced us. AI might kill us. And this is sort of sounded familiar. And obviously, AI is not the same as other technology disruptions. It is different. I'll address that later. But something about this sounded a little bit familiar. And let me start with sort of my personal sort of experience basis. So I've seen a lot of technology. So let me start with a personal anecdote. So in high school, that's me, obviously. By 1983, I've been asking my dad for like 8 years, every Christmas, to buy me a computer. And back then, that was a very expensive item. We didn't have a lot of money. And every Christmas, there'd be an empty Christmas tree. So one day, there was this cable TV show. They were giving away a computer. I sent in 8,000 postcards for each member of my family. 8,000, they picked mine. And so what will always stay with me was what the host said about technology. And you can read the text, but I'll put the audio there.
Very good, very good.
Okay, congratulations, and I'll be talking to you sometime Monday. Thanks, Seth. Bye.
Well, that sounds like a pretty happy and excited winner, and I guess any one of us would be if we had an opportunity to win a set like this. Although, at this particular time in the evolution of the personal computers, it hasn't become apparent to everyone yet how they can affect your daily life or really have much use in daily life. And that's what the personal computer show is all about, because we feel that the next great social tool for the individual will be the personal computer. And it will have as much impact on life in the United States as the automobile or as the introduction of television. It will have a major effect, and we here with the Personal Computer Show, which is a new type of a show on cable television, we'll try to stay up with that and keep you informed of this new social tool and all that it can bring into your life. But we hope you.
At the end, he says, please send in your cards and letters. I was going to make a joke about a third of this room's like, well, what's cable TV and what's cards and letters? So, can I just have like 5 minutes? Okay, I'll go kind of quick. The reason I bring that up is that's always haunted me about predictions. And I've worked in the technology industry for 3 decades. And then before that, I was, playing with them. And there's a couple of things that I want to draw out. Some of these are maybe kind of cliche, but we're really bad as a society predicting the harms of technology, and both how little and how much harm they can do. And these are just some examples. So, famous sort of cliche of Socrates sort of questioning writing and sort of damaging cognitive abilities. I don't know if you know, but the church actually produced a document prohibiting crossbows because it made it too easy to kill people. Gutenberg, very famous example. The novel, it's going to rot people's minds. The phonograph, this was a big issue. The fact that you could capture someone's voice and then replay it. New York Times wrote an article, editorial, that now people won't trust each other because they don't know if it's a real person. Sound familiar? And then the automobile, like other labor-saving machines, this is a consistent theme. Oh, it's going to make us lazy, right? And again, it's not to say that technology is neutral. Cars kill more people than horses, 55,000 people a year in the US, by the way. So one of the, I guess my observations that I want to kind of bring up here is a little bit of a counter to what I hear a lot of conferences is I'm observing what I would call technology determinism. It's actually not, it's coined in a paper I'm going to summarize in a bit, but I'll add moral determinism. There's this sort of implicit model that we're going to be impacted upon by technology and we don't have much agency. My view is I'm not a techno optimist. Maybe I'm a pessimist about human nature. And what is persistent and perennial across all these stages of technology introductions is people. And much of the, quote, harms that I see about technology is really channeling, amplifying, catalyzing human character. Since we're in a Catholic conference, let's just call it sin. Okay. So, and to kind of put a point on this, this is an anthropological, theological sort of like center of focus. And let's look at a massively peer-reviewed body of work over millennia about the nature of humanity. So, the Bible, right? So, I was thinking, well, how much of human character flaws are introduced in the Bible and by when? And it goes by pretty quick if you don't pay attention. By chapter 6, right? By the way, and if you were to equate this to, let's say, a 300-page book, that's page 2. So this is the important part of the iceberg, upon then which I think issues of technology, other societal things, I think then need to be discussed. One paper I found that sort of builds on this is in a psychology journal, Amy Orban, Sisyphean Psychotechnology Panics. And the point here is not to say, oh, all will be well, we don't need to worry about. It's perhaps we're not worrying enough about things that are really, really big issues. And one thing she observed is this cycle, and I'll jump to some of her observations. I'll show 3 first. One is technology panics, what she calls it, are not new, like I said before. And there's a systemic set of issues that drive this. And in the modern day context, what she observed is it's just fancy to always talk about bad news. It funds grants, politicians latch on. There's a symbiotic relationship between researchers and politicians. And so it just creates this sort of like, land grab towards what is the latest thing to panic about. And then the consequence of this is that actual progress is impeded. The wheel is reinvented with each technology introduction. There's no like baseline kind of theoretical framework that spans across all these introductions, which are, I would argue, anthropological and theological. And then last thing, 2 more minutes. The third thing I thought about is, okay, what do we do about it? So then it comes down to impact, particularly from the church. And let's be realistic. There's a couple of drivers of societal change. One is capital allocation. And in AI, that barrier is even higher, the billions of dollars that it takes for data centers. There's governance, but that requires real political power, right? And then there's cultural change. Where does the church fall within that continuum? I would argue it is really cultural change. We can talk about everything else, but we don't have the dollars, we don't have the politicians, we can't enforce it. So then how is that culture change affected? And there's different factors, but one thing that I've kind of observed is language. There is linguistic normativity, I just looked it up, that's a word, but there is language embedded in our mainstream culture that comes from the church. And just a list of examples, and I'll just close with, as I'm being told to get off, on double effect. A couple of weeks ago, my wife and I were watching The Pit. Let me turn the volume on. If you can't hear it, I'll just summarize what it said. Okay, just in interest of time, you can't hear it. There's a hospice patient that came in and she's in a lot of pain. She asked for more morphine, and knowing the risks, they administered it. Younger doctors like, well, what are you doing? And Dr. Robbie explains double effect. Now he kind of says something at the end about, well, maybe death is the preferred outcome, which is not. But my point here is that, this is a Catholic principle. It's made it into a #1 rated TV show. And one of the things that I'd like to see that come out of in terms of kind of further research is 2 things. One is, what can we learn from this past technology sort of panic, whatever, that we can build on for true impact. Second is a study on really true cultural societal change that the church has driven through this change in vocabulary and vernacular. And maybe one dream is in the world of AI, when robots are manning hospitals, there's an engineer in China that remembers a principle but doesn't know where it comes from, but it actually came from the church. Thank you.
Thank you both so much. We have about 7 minutes we've set aside for questions, so you better make them good. I think that we have some folks with mics still, do we? Or I can run them. Who do we have with a question? Got all the way in the back there.
Hi. My question is mostly for Mr. Kim. I was curious in your vision of thinking about robot staffing healthcare services. I'm curious where your thoughts around like the dignity of work go in, and just thinking about the money that we are investing in developing AI in order to do the kind of companionship labor for elder cares versus investing in dignified wages in order to like get people to perform the kind of connection work. And I'm just curious what your thoughts are on those pieces.
Sorry, what is your name?
I'm Julia. I'm a
Julia?
first year MDiv student at
Okay.
BU.
That's a great question. I would base my answer on other changes that I've seen with automation in my career. And I think there is often an initial fear based on job displacement, whatever, based on existing roles. But what we have seen is new roles are created, new efficiencies are created. If you go to a modern factory now, there is a lot of backbreaking work that has been removed by automation that could not have been foreseen. Now, that might sound like a trite kind of tech utopian answer, but I offered that as a counterweight to kind of the typical question that I hear about, what about job displacement and dignity of work?
Hello, I'm Nicholas. I work at MIT, directing an ethics program whose mission is to challenge uncritical narratives of technological progress. So I'll be speaking on behalf of technology panics. I'm kidding. But I do have a question about to what extent you think our responsibility as Christians is to challenge empire. I mean, I think it would be naive not to say that techno-capitalism represents a dominant form of empire today. And while I appreciate, so we can lay out the field here and say, well, AI could take us this direction, could take us this direction, we want to go in this direction. But these products arrive in our world with a tremendous momentum owing to the ideological, economic, political, and structural power of the people who are developing these technologies. And I appreciate the openness and not condemning all of industry, but I work with students and I work with alumni who can't be as critical of the dominant ways of doing business as they'd like to be. And they actually come to me as a chaplain and as an ethicist, hoping that I can be their voice. And I think any of us, working in healthcare, we know what it's like to see the power of the economic incentive if we worked for Catholic healthcare and trying to maintain a sense of mission and seeing it get sold out to the highest bidder when money is tight. So I'm just curious how to, and I really appreciate everything you're talking about. So it's really more of a question of balance. How do we maintain that openness to relationship as Catholic ethicists and practitioners while also retaining the importance of critiquing empire?
Is that a question for Paul?
Anyone?
Yeah, I mean, no, I completely agree there. I mean, there is a huge momentum going behind the tech industry. Louis, I appreciate that we can't demonize the tech industry, and I don't think people have bad intentions in there. But it's sometimes the people with the good intentions that I fear the most because they have this belief that this thing will be unqualifiedly good, and that can lead to just as damaging problems. But yeah, and I think even a lot of them in the industry feel their agency is constrained by the momentum of kind of technological advance. What I think is a moment of hope is that we don't have to accept these products blindly. I mean, institutions that are developing them, and I think a lot of Catholic institutions like education, healthcare, they have the ability to choose which one of these they implement and how they implement these tools. And I think that is a moment where Catholic healthcare, the church, has a lot of kind of potential for moving the needle. I'm a little bit concerned about like pointing towards the tech industry as something that we can necessarily change, like where the momentum is going. But I think as Catholic institutions, the people who are buying these things have a great deal of possibility for opening up new futures.
Just to follow up quickly, what I understand from the question is you have these enterprises that are empires. They wield huge power, and it's not clear that it's always for the good. And how do you guide students to sort of navigate that in a discerning way, while and also appreciating the fruits of that enterprise? But I would go back to what I said about human character. Empires are as old as, Exodus, right? Cesar Chavez last week, Noma restaurant. Tyranny and power and the abuse of that is everywhere. It's in your universities. And so my point about saying that let's not demonize an industry was not to whitewash that industry. It's to recognize there is sin at scale everywhere. And if we don't recognize that, we sort of finger point and cast people on different kind of black and white categories, and it's not productive. It's not productive. And what I see, I sit on nonprofit boards, I'm in industry, I go to these conferences, and people don't talk to each other because we've made them into comic book characters. That's my point.
So I think that we have time for one more super quick question, if we want to go ahead.
Hi, I'm Kathy Chang. I'm the Senior Director of Spiritual Care for Ascension. And my question is actually a very basic baseline question, which is whether there are any studies of what patients want generally, and whether or not they're okay with the solution being provided by AI. So for instance, I could see that a patient, like for myself as a patient, that I would be fine with I want a fast ability to make an appointment, and I'm fine with AI helping me with that. But if I say want a behavioral health specialist to help me, I am not fine with an AI behavioral health specialist. And I'm wondering if there are any studies that you know of that might get into that kind of detail of patients and what they're willing to accept and not willing to accept from AI.
I don't know this literature in depth, but my sense is that it's very messy. So different studies will show different things that, in general, if you say an intervention was done by AI, people will kind of have skepticism. But there are subsets of the populations, people with certain mental disorders, who will prefer to go to an AI because they won't feel judged or something like that. So it is kind of messy and developing literature right now, as far as I know.
All right, please join me in thanking our speakers, and then it is time for break.